good evening. 2012 has passed very quickly. I wish to thank all of you for watching, but more importantly, I wish to thank you for listening and making those small changes that add up to a much healthier and happier life. Please keep your emails coming, as I love hearing from each and every one of you. Make this year best year ever, one small change at a time, because time waits for no one. Any one of your family members has a high blood pressure? I'm sure you heard that term. High blood pressure harms multiple organs in our body: the heart, brain, kidneys, and eyes. The first heart sign for blood pressure is thickening of the heart muscle, leading to struggle in pumping blood to the circulatory system. Over time, blood pressure could lead to hardening of the arteries and building blockages and narrowing the arteries in your heart. When that narrowing reached to the critical point, that could result in a heart attack, leading to a permanent damage to your heart and may result in a heart failure. Blood pressure or hypertension is the leading cause for kidney failure. It affects the capillaries or the small vessels in your kidney, leading to breakdown. Damaging those vessels in your kidney will affect the ability to filter and clean blood, and if left untreated, will lead to failure, and subsequent to that, you could end up on dialysis machine. One of the other major complications for hypertension or high blood pressure is to affect the arteries in your retina, in your eyes. That will lead to bleeding or blockages, which could lead to blurred vision or loss of your vision. The most devastating complication for hypertension or high blood pressure is stroke. As you know, high blood pressure is #1 cause for stroke in the United States. The reasoning for that high blood pressure will lead to hardening the arteries, which could lead to one of two possible complications. The first one is blockages in the arteries, which lead to shutting down the circulation in a small portion or part of your brain, leading to the stroke symptoms, which is probably you saw some of the patients having weakness in their left arm, left leg. The second possible complication is rupture in those arteries, leading to hemorrhage or bleeding in the brain, which is also will lead to similar symptoms called stroke. Hypertension is the silent killer. It's #1 killer in the United States when we look into the complication produced by the hypertension. You need to remember that the normal blood pressure, as advised, is to be less than 120/80. 120 is the higher number, 80 is the lower number. When you get to the blood pressure more than 140/90, that means you are at higher risk for stroke, and that will increase your chance by about 40 to 50%. If you are diabetic, your number should be different. The higher blood pressure than 130/80 considered higher risk for stroke. So you need to understand how important as a diabetic patient to have a lower blood pressure than the person who is not diabetic. Why we called hypertension silent killer? Because many people, they have a high blood pressure and they don't know. In general, you need to check your blood pressure when you go to your family doctor, but also if you have a family history, if you are overweight, if you have heart problems, if you are diabetic, you need to remember that probably you are at higher risk to have a high blood pressure, and you should check your blood pressure on a regular basis. Now, after we talked about hypertension, let's talk and discuss stroke, which is a major complication, and show you the details how is the stroke happening. And also, we are going to talk to one of the experts who really going to help us and guide us step by step how we could manage the stroke when it happened at the right time, appropriately, to avoid having the major complication of losing our control on our. We'll come back.
The Minx Grip vascular closure device from Access Closure. The Minx Grip vascular closure device offers an active, extravascular, patient-friendly closure solution that enables durable hemostasis without sutures or implants. The Minx Grip sealant is delivered through the existing procedural sheath, eliminating vessel trauma that is often caused by sheath exchange and tissue tract expansion. Temporary hemostasis is achieved first by placing an intra-arterial balloon, followed immediately by delivery of the Minx Grip sealant, which is positioned on the surface of the artery. The Minx Grip sealant consists of polyethylene glycol, commonly known as PEG, and is comprised of two sections, the grip tip and the Minx sealant. The grip tip is a new configuration of PEG that allows the sealant to actively adhere to the artery. The Minx sealant is freeze-dried and porous, allowing it to expand in the tissue tract. Together, the grip tip and Minx sealant achieve a durable hemostasis. After delivery, the Minx Grip sealant is compressed, accelerating expansion and adhesion to the vessel wall. The grip tip consists of two PEG components. Once the grip tip enters the tissue tract, the body's temperature and pH level causes these two PEG components to react and cross-link. As the cross-linking occurs, the grip tip softens and interlocks with the contours of the vessel wall, effectively gripping the artery and providing active closure. After the initial sealant expansion, the balloon is deflated and the device is removed. Platelets and blood cells continue to collect inside the Minx sealant's porous matrix, causing the sealant to swell 3 to 4 times its original size. Together, the Minx sealant and the grip tip produce a durable hemostasis and a platform for natural vessel healing. The sealant dissolves naturally through hydrolysis. Within 30 days, the sealant is completely reabsorbed, leaving nothing behind but a healed artery. Minx Grip grips on contact and leaves without a trace.
Welcome back. Today we are going to finish our discussion about the stroke. And as you remember, we had the concept of dividing the stroke between ischemic and hemorrhagic, or the bleeding stroke. And we have one of the experts who is an interventional radiologist to discuss those options of treatment with us. Today it's my pleasure to welcome to the show Dr. Morag. Welcome.
Thank you very much.
So really we want to use your expertise to tell us in a simple way about the best treatment possible these days for the stroke patients. You know, we are trying to tell the patients to rush to the hospital as fast as possible because of the new studies which is suggesting that the sooner you get to the hospital, the better the treatment we get. So would you just summarize those treatments from your standpoint?
Right, so you know, I just want to emphasize, as you mentioned before, that we, for most part, we talk about the ischemic strokes, which affect approximately 90% of the population. And as far as the options that we have for treatment these days are all included in what we call the minimally invasive approach, where we basically treat the patient through a little opening in the groin in a very similar way to what the cardiologist will do for the heart and the vascular surgeon for other parts of the body, and we basically insert a catheter within this critical time period that we all kind of discuss and know, between 3 and 6 hours. Mm-hmm. Where we put that catheter in a selective way into the artery that is occluded. I mean, that stroke is caused by occlusion of an artery. And the purpose, obviously, is to open this occlusion and basically get the blood back to the brain, to the area that is affected. So we have several options. The most common one would be opening this narrowing with a balloon, again in a similar way that's done in other parts of the body. Sometimes we need to support that with a stent, which is this metallic scaffolding that is used also in other places. And often we will put the catheter after we open that occluded segment next to the affected area and infuse solutions that can dissolve clots.
Pleasure to have Dr. Greg Casper, who is the Chief of Vascular Surgery in Mercy St. Vincent Hospital, to discuss the follow-up for the stroke patient as we discussed before. Now, the point which we are trying to discuss today is related to the carotid disease. Greg, welcome on our show.
Thank you very much for having me, Ameer.
We presented some examples about stroke patients, and one of the elements about the etiology and the reasons for stroke, and one of it is related to the carotid stenosis, which is, you remember, it's a blockages bending up in those carotid big vessels, could lead to the stroke. And we're going to show some examples of your patients where you're doing a tremendous and very successful procedure. Would you give us some information about the relationship between the carotid disease and the stroke? How frequent? What is the best modality to diagnose it, and how to treat it?
Exactly. Everybody has 4 blood vessels that take blood flow up to the brain. As you know, and the 2 carotid arteries that go up in the front of the neck do most of the work. At about the angle of the jaw, they split, and they give off a branch that supplies the muscles of the face, and the other branch goes straight up to the brain. And it's very common to get some buildup of plaque in that area, typically from smoking, high blood pressure, high cholesterol, diabetes. Genetics play a role. We see that in aging. The same risk factors you see in cardiovascular disease make patients prone to this as well. And what can happen is significant narrowing in that area can lead to what we call embolization, which is a piece of plaque or clot breaks off and travels upstream. It can lodge in the brain, and the patient loses function of that portion of their brain, and that can be a significant and devastating stroke at times. Simple way to look for it, a lot of times physicians will listen and they may hear turbulent flow in the carotid arteries. We call that a bruit. If they hear that, then it alerts them to go ahead and check an ultrasound. And a simple ultrasound is a non-invasive test, no needles, no drugs, doesn't require anything invasive, and that can give us a good idea if there's significant plaque going on there and if we need to take further measures.
Now, when we are talking about those ultrasound or Doppler ultrasound for the carotid, and we get different reports, if there's any idea, because we always give the patient some percentage. Do you mind to tell us the details of those percentage?
No,
I mean,
exactly.
when they should be curious and interested in follow-up with the vascular people to decide about treatment?
Exactly, great point. And we do those very commonly. A lot of the primary care physicians do that regularly, and I know we both do as well. And typically, ultrasound can give you a range. It can't tell you exactly how narrowed something is. Typically, the ranges will be 0 to 15%, 16 to 49, 50 to 79, 80 to 99, or 100%. And certainly more concerning if it's in the 80 to 99% range, and that's someone that needs to be evaluated and treated, within the next few weeks. If it's in the 50 to 79% range, then that's usually when we say some evaluation by a vascular professional or vascular specialist is going to be warranted to help delineate exactly where they're at in that range. More towards the 50% range of narrowing is very safe, not very much risk, but needs to be followed perhaps every 6 months with repeat ultrasounds. When you get up more towards a 75 or 80% narrowing, that's when you need to consider other risk factors and say, how dangerous is this, and what can we do to help reduce that patient's risk of stroke long term?
Saying all of that, also, if we have a patient questionable, like less than 49%, and they have symptoms, they should not take that as a percentage, as a solid. We should do further evaluation, like when we tell them to go and see you guys, to do the angiogram to be accurate, because those ultrasound not 100% accurate. Is that the case?
You are exactly right. And I think if you've got a patient that's asymptomatic and it's less than a 50% narrowing, you're pretty safe in watching them. But if they're having symptoms and you're concerned, and you can look at the ultrasound a little more closely, and that's something that certainly someone who interprets vascular studies can do, to see if the plaque is very irregular, if there's what we call ulcerations. Mm-hmm. I always tell patients an ulceration is like a pothole, and what do you tend to see in the pothole? You see gravel. So there can be loose debris. So that can be a dangerous sign too, of plaque that's not significantly narrowed, but has some significant factors that need to be evaluated further.
And if we find the patient have significant symptoms and significant blockage by the Doppler ultrasound, and you confirm it now, would you summarize to us the treatment? I know that there's 2 approaches, and probably you need to give us some information about it.
Yeah, if it's a significant narrowing and there's a significant risk of stroke to that patient over the next 3 to 5 year period, then we might do some intervention to reduce that risk of stroke. And the 2 interventions are typically an angioplasty or stent, or carotid surgery, where we go in, make an incision on the neck, and clean that plaque out.
There are moments when we place our lives in someone else's hands. Moments of trust and faith. Moments of innovation, like conducting the region's first robotic surgeries. And moments of joy, like when Melissa could laugh with her girls again. the moments you know you're in expert, caring hands. These are the moments of mercy.
Is your heart clock ticking? It's time to change your future with Toledo Cardiology Consultants.
Getting men to change their lifestyle is leaving their wives and children very frustrated. Men seem to think that medication is a fix. It's like putting medications in the big cheeseburger and expecting to be healthy. Come on, guys, you can do it, one step at the time.
To learn more, go to WTOL.com, Health Track.
Because time waits for no one.
Yes, this situation changes your life. It takes things out of your life, but you want to come out of it with your life. And I want women to know there are so many resources. If I was gonna get cancer anywhere, I thank God I got it in Toledo. You need to get treatment so that you can stop the growth of the cancer and stop it from invading your body. You can't weigh your life against a hospital bill.
I never thought I would be a victim of a stroke. I never thought this was something that could happen to me. I'm Teddy Bruschi, husband, father, professional football player, and stroke survivor.
Today we are going to discuss few elements about stroke treatment, and I want to emphasize how important to the patients that if any one of them or any family member having signs of stroke, where they should go.
One of the current controversies in stroke medicine revolves around the point of care for patients suffering from ischemic stroke symptoms. And so traditionally, folks that have stroke-like symptoms were told to present to their nearest, closest emergency room. Much of that was before the availability of neurointerventional treatments and comprehensive stroke centers that exist today. And today the game has changed somewhat in that when people have stroke-like symptoms, they may be, in fact, better served presenting to a comprehensive cerebrovascular center capable of doing everything from basic medical emergency management, complex imaging, neuroimaging, and also selection of the correct patients for neurointerventional procedures. And our program is an example of one of those. And so for modern stroke patients that present with stroke-like symptoms, the game has changed somewhat in allowing them to pick from an option of comprehensive stroke centers to allow the full spectrum of care to be delivered for whatever the eventuality. It would be the cerebrovascular corollary to somebody with angina presenting to a center without the full scope of cardiac intervention in the world of cardiology today. So of care can be delivered.
If we go right now, that patient arrived into the emergency room and we're going to treat him as a brain attack, like a heart attack. What are the steps which is that patient is usually going through based on the criteria or the protocol right now you have as an advanced center to treat those patients?
And these days we have a lot more evidence-based medicine to go by, so we take our cues, of course, from the American Stroke Association, American Academy of Neurology, and the Neurocritical Care Society. And very much like the cardiac spectrum of care, our care begins actually in the field, and we try every day harder to push that emergency first-line care back into the EMS vehicles, the ER level of entry of the patient, and really provide aggressive physiologic assessment and medical management on the way through a secondary step, which is typically neuroimaging to select who's most at risk for what procedures and who can benefit from what procedures. A lot of that new comprehensive neuroimaging is done. Patients are selected for the appropriate next step medically or surgically based on those initial images generated, and then it's often very easy to bring those patients directly into an interventionally equipped lab like the one you see here for advanced procedures if they need it, and then in context with a dedicated neuro ICU and supportive rehab facilities that allow the patients to get the most out of the spectrum of their care that they can get and get as better as they can get from the disease process that originally brought them in.
We have to mention that stroke is considered like the third common cause of death in the United States. It's so important to address it and immediately rush into the emergency room, and that's what really we are trying to talk about, to save life, to save also some kind of injuries coming out of from the stroke. Now, in the past, we used to talk about if we have a stroke, the most important thing is to get to the emergency room so that we can give them what we call a lytic treatment, try to dissolve those clots, assuming that it's ischemic stroke. Is that the only option we still have? Or right now with the advanced technology, and that's why we have centers as big as this one, there's much more can be done?
In fact, that's true. Quite a bit more is able to be brought to bear on stroke than ever before, I think, today. The gold standard has typically been to assess folks in a window of about 3 hours or under and bring those folks to IV lytic therapy with peripherally inserted IVs that deliver clot-busting medication, or IV TPA. to the whole body and thus the cerebral vessels in the head. Some literature has come out in the last couple of years that has extended that window up to 4 to 4.5 hours under the right circumstances and with proper neuroimaging. In addition, we have literature that indicates that we can do more with intraarterial or IA TPA when and where that's warranted, as well as mechanical embolectomy or mechanical clot extractions that actually go on in an interventional lab like this for folks that even are out in windows of 6, 8 hours or 12 hours or more for the right physiologic circumstances. But again, key in that is patient selection for safety of the right people to revascularize and which people are not the right people to revascularize. And that's part of what makes a comprehensive center with all its working parts such a powerful thing to bring to bear on stroke today.
Quickly, we performed a CT angiogram to help identify the blocked artery. The blocked blood vessel is too small to clearly see. We need a better test. A CT perfusion scan clearly shows an area of brain that is not getting sufficient blood flow. Green means the brain tissue is still alive and may be helped by restoring blood flow. I started an emergency angiogram entering her arterial system at her left groin. I passed a catheter, a small plastic tube, from her femoral artery up the aorta and into her right internal carotid artery. These are the arteries of the right side of her brain. We are looking for a vessel that flows slowly or stops prematurely due to a clot. Looking closely, we can see that there is a medium-sized branch that does not flow properly. Now, magnified, we can see that the blood flow stops here. To illustrate, let's look at the middle cerebral artery of another patient. I highlighted the blocked branch that we need to open in our stroke patient to help her symptoms of numbness and weakness. To open the branch, we're going to use a penumbra aspiration catheter. Through it, I will pass a separator that will break up the clot. The catheter is connected to suction to pull away pieces of the clot. The tip of the separator is very soft and doesn't traumatize the vessel. I have advanced the aspiration catheter into the affected branch. Now, moving the separator back and forth across the clot, we can try to break up the clot and carry pieces away with suction. I will inject some contrast to see if the vessel is opened up. Now we are starting to get some flow through the branch. I will make several more passes back and forth across the clot. Our goal is to clear as much of the clot as we safely can, if possible, fully restoring flow. Now the vessel is flowing much better, maximizing her chances for a recovery.
What about hemorrhagic, the bleeding stroke? I mean, that's another common problem. We see it sometimes. So what is the newest treatment or management at this point?
Current therapy as well for hemorrhagic stroke encompasses a variety of specialists and different techniques. Traditionally, folks that come in with ruptured aneurysms or AVMs or intravascular malformations in the brain have been traditional surgical candidates. In the last 10 or 12 years or so, more and more is being done minimally invasively for that. And a good portion, perhaps 80–85% of ruptured aneurysms or other vascular abnormalities in the head today can be treated minimally invasively in context with a global neurosurgical assessment of the patient to give people an additional tool in the arsenal to treat intracranial vascular ruptures. Probably by far the most common is an aneurysmal rupture or AVM rupture. We see a good variety of those each year. Again, that's another entity where time is brain, and so for a lot of those people that rupture a vessel, they have rises in the intracranial pressure as a result of extra fluid being in the head, which is a closed space. And even if the initial injury of the ruptured vessel doesn't hurt them or kill them, the precipitous rise in pressure in the head without traditional neurosurgical assessment and evaluation and treatment can very often take the patient's life. So again, that's another important facet to being in the right place at the right time with a broad scope of care like St. Vincent's.
There are moments when we place our lives in someone else's hands. Moments of trust and faith. Moments of innovation, like conducting the region's first robotic surgeries. And moments of joy, like when Melissa could laugh with her girls again. The moments you know you're in expert, caring hands. These are the moments of mercy.
Why become a foster parent?
I wanted to give back.
I wanted to help a child.
It's something that I felt called to do.
We heard about the need and we knew we could do it.
We missed having kids in the house.
Being a foster parent just fits with our family.
I'm Dean Sparks from Lucas County Children's Services asking you to become a foster parent. Call us at 419-213-3336, visit us at lucaskids.net, or find us on Facebook.
I started to think, what shall I do next? What do I want to do for myself? Going through this cancer process. Just one day I just said, I'm gonna fight this to the end. I got too much to live for, and I'm gonna keep pressing on. And I was very happy, you know, to hear that there was help. And I know Susie G. Komen Foundation is very helpful and support you. And I was happy what they do for women.
Through my college and pro career, there's about every injury you can name possibly that I've had, from my ankles all the way to my neck, and from pain levels ranging from 1 all the way to 10. A recovery from an injury that you can control is much more easier to rehabilitate from. When I had a stroke, there were some aspects of my recovery that I had no control of. I lost part of my vision. These are some things that you can't rehabilitate on your own. You just have to hope and pray that the right decisions are made, the right procedures are taken. When I got home those first few weeks after the hospital, I think it was just about healing for me. My energy level was very low. I would get tired just getting up from the couch or walking up the stairs. My fatigue level was very high. Emotionally and physically, I was pretty beat down. Pretty much in my mind, football was out of the question. Getting to the point where I could still run with my kids and still pick them up and still be able to play baseball with them was something I wanted to do. After my first few days at home, a visiting nurse came and saw me, and she helped me with rehabilitation. The basics of walking, of using my arm again, of writing my name again, seeing how my vision was doing. It was very slow at first. The type of exercises my rehabilitation therapist had me do varied from very elementary things to balancing on my left leg. I really didn't think it was possible to come back to play professional football after a stroke, and really, I didn't want to. There was a moment I had in my bedroom when I was asleep, and it was in the middle of the night, and I sat up in my bed and I looked at a clock. With the deficits I had in my eyes, if a clock said maybe 10, 12, I would see 0, 1, 2. I wouldn't see that 1. So at this particular moment, I knew what time it was. It was 12:23. And I'll always remember that time because I could see that 1, I could see that 2. That was really a moment for me when I said, I think I can see again, so maybe this is possible.
It's so important. If you remember when we started this program, our goal is to introduce to the community all of the advanced technology in this area. We should be proud in our town that we have a program and a center like that who is providing that kind of services.